Okay.
So can I share this
So-
link on Twitter?
Yeah, sure. Yeah.
So people can join if they come to this link?
They can join this call, but it would typically be easier if they just join the YouTube link where they can just stream what's going on.
Oh, okay, I see.
Yeah, so I think is your Twitter open? Let me send you the link on Twitter.
I'm sorry, say again?
I said, is your Twitter open? Is your phone closed? But let me just send you the link to the YouTube.
Yeah, my Twitter DMs are open, yeah?
All right, sure. I'll send it right away.
Sure.
All right. Okay. Aha. So I just sent the link and we are live, so can get started now. Hi, Precious. Thanks for joining in. So, hi everybody. Today we are having Daniel. Daniel is a product designer and a product manager. Sorry, guys. Just a few seconds. Yes. So we're having Daniel today, and he's a product designer and a product manager that has been focused on solving complex global health issues. So he's just been doing this for a very long time, and he has one of the most impressive careers I have seen. Honestly, I was just telling him that before we went live. So he's been on Google, he's been on Slack, and he was just telling me that he drew the original version of the Firefox logo. How cool is that? How cool is that? Honestly, like I don't know how young I would have been when that logo came out. So it's so cool to know that I am talking to the person that drew the original version of that logo. That's super cool. Thank you so much for doing this, and I think we'll just jump right into it and we'll just get started. Hi everyone in the comment section. Don't forget to drop your comments, your questions, whatever you have. We'll see it and we'll answer. So Daniel, hi.
Hey, thanks so much for having me on the show. It's great to be here.
Thank you. Thank you for agreeing to do this. So we'll start by talking about human-centered design because we have an audience that is largely just newbies and beginners and people who don't really know much about design. Would like to give them, just some foundation. So tell us.
Tell us about what human-centered design is?
Yes.
So, I mean, human-centered design seems like something that's really obvious, right? It's like, oh, let's make tools or products or design work that is built intentionally to make humans' lives better. This seems like an everyday thing. And I remember when I was young and I read Jacob Nielsen's kind of writing about human-centered design, I was like, oh, that seems obvious. But then you look around the world and you realize how many things are not designed in a user-centered way, right? So it's a product that's designed primarily by a business in order to optimize business performance, or it's in my case, in healthcare, it's a tool that's designed for data collection as opposed to benefiting patients or, healthcare workers like nurses and doctors. You look around the world and there's tons and tons of things that aren't designed for users primarily, even things made by designers. If you look on Dribbble, there's lots of things that are optimized to look cool, for instance, as opposed to what's best for the customer. And I think that's where we often fall short as designers, is we either optimize for the business or we optimize for design, or we, listen to stakeholders as people defining the characteristics of what we're making instead of listening to the users.
I think listening to the users is a big one because depending on the kind of company you work in, a lot of times one of the biggest problems is that the stakeholder wants one thing and you think it should be a different thing. Actually, yesterday, this came up a lot in the conversation I had with Amy Rogers, where we were talking about how to handle stakeholder inputs or your line manager's inputs or the input of people above you. So yes, I know that's a little of tangents, but I'd also like to hear from you how you handle such things.
Right. So in our case, in health, for instance, what happens a lot of the time is you speak to people who are in positions of authority. So either people run health programs, usually at like a Ministry of Health or in a government, or senior managers who run, a large hospital group. And you'll talk to them and they'll have a very specific perspective of how healthcare should work. And usually they're thinking about the system, right? It's like, okay, if I understand, this data about which patients are being treated and what outcomes they're having, therefore I'll be able to shape the program, which is one perspective. So don't get me wrong, it's not an incorrect perspective, but it's one perspective. And so the challenge is when those people dictate the entirety of a product, you end up building a product from only one perspective. Whereas if you're able to implement user research, for instance, you're able to go in and watch how actual healthcare workers deliver actual care. So not an abstract, not in the textbook, how should healthcare workers deliver care. In actuality, based on the constrictions of everyday care, how is care actually being delivered? And then to go to patients and look at what kind of care do they actually want and what kind of care do they actually need. Oftentimes, these things in an ideal world wouldn't be at odds with each other, but in the real world, they're often at odds with each other. Somebody in, a Ministry of Health will say, well, I need these 52 pieces of data in order to understand treating hypertension, for instance, high blood pressure. I need serum creatinine labs. I need 2 blood pressures at every visit, and I need to track, patients every 7 days. In reality, healthcare workers are seeing, I work primarily in India and Bangladesh and Ethiopia. And in those places, a healthcare worker will see up to 150 or 200 patients a day, right? It's unbelievably high volume patient care. So they have maybe 2 minutes per patient. At 2 minutes per patient, there's no way you can take 2 blood pressures. There's no way you can record a serum creatinine lab. And there's no way you can fill in the risk analysis of every patient. And so the person in the ministry might be, the stakeholder might be asking for 52 things. But if I've done my user research, I can come back to them and say, listen, none of the patients can stand in line for 2 hours every 2 weeks. They'll just stop coming to care. None of the healthcare workers can take 2 blood pressures, and they certainly can't do a serum creatinine lab in 2.5 minutes. And so let's be realistic. And you come back to them with good current data from the field, and they're not monsters. They're just bureaucrats, right? And so they don't want to make healthcare workers' lives harder. And if you're able to bring real data to them because you did qualitative and quantitative research in the field, you're able to then create a system that involves everyone. The bureaucrats need certain data. The patients need certain data. The healthcare workers themselves need certain data. And as a designer, it'd be interesting. A lot of, I think some people on this call are at the beginnings of their career. The further you get into design, sometimes you realize that the biggest role you play is being a moderator, is really bringing the different voices together and helping good, rational decisions be made so you're able to design an effective system. I'm not talking about like individual little design choices. I'm talking about like the entire system and how the flows all work and how the interactions between patients and their doctors work. And all of that fits together so you can have a health system that is functional. Systems design.
Interesting. So you've mentioned user research a lot, and I would like to know so for public health, does user research differ from what somebody like me would do for, say, a social media product, or is it the same processes, the same things pretty much?
Well, user research is a big umbrella, right? So there's many types of user research, there's many techniques to use. So I think some techniques that you'll see in consumer software still apply well to healthcare. There are more considerations around things like patient privacy, and more concerns about getting in between patients and their doctors, right? You don't want to interrupt actual patient care, which is quite difficult in some places. But many of the techniques are similar. It's observing people, it's talking to people about kind of what their challenges are, what their day-to-day workflows are. The biggest challenge between typical consumer software research and healthcare research is a lot of healthcare delivery happens in teams. And so what you want to do is look at kind of the ballet in the hospital, if you will. It's like, okay, the patient comes into the clinic, they get registered at the outpatient desk, they see a triage nurse, then they get sent to a different room. The next person takes their blood pressure, they go to the medical officer has certain powers to be able to do like diagnosis and treatment. Then they come back to the pharmacist to get their medicines before they leave. Somebody counsels the patient and then they leave with some information. And all of those people, in an effective healthcare system, it's really, you hear the term team-based care a lot. And that group of people kind of work in concert to make sure everybody's understands enough about the patient to be able to do their role successfully. And so the patient is treated along a continuum of care. So you really have to kind of go a little bit broader than just like, oh, this works for the one person. You could solve, kind of a few problems by solving one thing at a time, but a lot of things involve understanding kind of the chain of decisions that happen and make sure that a lot of it's like unwinding the kinks in the system to kind of create a more efficient system so patients aren't waiting around as much, so data doesn't get lost between steps. If the nurse takes your blood pressure when you first come into the hospital and 2 hours later you see a doctor, hopefully the record continues so the doctor can see, oh, what was your blood pressure 2 hours ago? So she takes your blood pressure now and can average the two and knows what your average blood pressure is and is able to diagnose you on the spot without you having to come back in 2 weeks. Mm-hmm. Right? That's the kind of thing where you're like, oh, okay, how can I make this continuum work so the right data is in the right place to make the right correct decision for the health of the patient?
Aha. So this actually means you have to talk to a whole lot of people and look at everything as a system. It's no longer just talking to a few people and you're like, oh yeah, I got it. Let's get to work. So it sounds like a lot of work.
It is. It's a lot of work, but it's really satisfying. One of the things we do, at the beginning of the project, we spent a lot of time following patients around hospitals. We'd actually, I was in northern India and we'd ask them permission. We'd say, hey, you mind if I just follow along with you today, and you'd be some old lady, she's like 70 years old, 75 years old. And it would be me and someone who spoke Punjabi. And we would, just tag along with her and she'd go, check into the front desk. And over the next hour, you just follow her around the hospital and see kind of who's making decisions, what information they need to make good decisions, where she has to wait in lines. and you're like, oh, okay, I can see now how to improve that system. It's really enlightening.
So let's back up a bit. So how do you
Okay.
get into that sort of thing? Because I know that um, design in the public health sector is not something. It's not a job you see advertised anywhere. You don't see people say, "Oh, hey, we're looking for designers. Come on." So how do you even get into that sort of thing?
Yeah, that's a great question. Thank you, Angel. One of the problems in public health is that there aren't a lot of great tech roles in public health. There's a huge opportunity to make impact, but most of the public health programs kind of don't understand design, user-centered design, and most user-centered designers don't understand public health. So I think there's a lack of bridges in between the two. And that's kind of a bigger problem maybe I'll work on in the next decade or two. But so before this, I was at Google's venture capital arm, so called GV. I was a design partner in venture capital, which is a very lovely job. You get paid a huge amount of money to consult with startups that a venture capital firm invests in. And it's a very nice job. My team wrote a book called Sprint, which was really cool. And, we had a really good time there. But it's not super challenging, right? It's difficult, but it's not like the hardest work in the world. And I was thinking I'm too young to retire. And I've been very fortunate in technology. And I was like, I'd like to go work on something really, really hard and try to, do something to improve the world. And while I was at GV, I got introduced to Dr. Tom Frieden through a mutual friend of ours. And Tom used to run the Centers for Disease Control. So for President Obama, he was the head of the Centers for Disease Control. And so I met Tom, and Tom, his pitch to me, so I was still working at Google Ventures, and he comes to me and he says, Daniel, my goal is to save 100 million lives in the next 30 years from cardiovascular disease. I'm like, damn, you meet people who are ambitious in Silicon Valley a lot, and then you meet someone like Tom Frieden, and you're like, wow, you're very, very ambitious, and then he explains it to you, and he's like, it's not rocket science. It's not ununderstood. It's not new science. We know how to treat hypertension. We know how to treat hypertension at scale, but it's really, really hard in places like India and China, Nigeria, Ethiopia, very large, low and middle income countries that have relatively weak primary care systems. And he's like, one of the weak parts of the system is a data system. So you can build feedback loops so you know kind of where the hypertension control system is being successful and where it's failing. And he's like, many people have tried to build digital systems for places like this. None of them is, few of them have succeeded. We need to do it at a bigger scale because hypertension affects 1 in 5 adults. So we're talking about just 200 million people just in India. And he's like, do you think it's possible? And I was like, well, it sounds like a fun challenge. And so I left my job at Google and came to join Tom. So yeah, it's a rare job.
Wow. So in essence, it's not just something somebody just, sees. Because I feel like it's something that is important. When you told me whether to change your topic, and I looked at the topic, my first response was that I'm like, this is something we need to talk about a lot. Health is super important. Everybody wants to be able to live and live long and live healthy while at it, right? And at the end of the day, as much as we as product designers are very interested in being able to help users, we can help people who are sick. We can't help people who are dead either. We just build products for a certain type of people. So when I saw the topic, I was like, it is a conversation that needs to be had because we need to see more designers in such fields so that we can do what we can to keep more people alive and keep more people healthy. And I live in Nigeria, and I know that a lot of the times people die more from mistakes, more from lack of data. So somebody's giving a drug and there's no data to follow up, and somebody else comes along and just gives the same drug, and now it's an overdose, and next thing you know, somebody's dead, right? These things happen, and it's crazy. Yes. As much as would like to say, oh yeah, government, these guys, they're careless, but at the end of the day, like you're saying, if we're able to build up systems that mitigate these problems, that help people like you said, imagine somebody having 2 minutes to look at a patient. I mean, how much care would you actually give that patient if you had just 2 minutes? And obviously, this person is overworked, this person is tired, this person is exhausted, probably has not had a lot of sleep. So it's not that they're being intentional about allowing people die or allowing things happen to people. They are humans, right? So in the end, having designers in these kind of things would or in these career paths would be super important to be able to mitigate these challenges and reduce the number of deaths and healthcare problems as much as possible. So I would like to ask, are there unique skill sets that you think that a designer that, so say somebody's listening to us right now and the person's like, oh yeah, I see this, I feel you, and I would really like to try this out. Are there unique skill sets that you think that that designer would have to possess to be able to delve into something like this and actually do well at it?
Yeah, thank you for the question. There are some things that are different about designing in public health. There are many things that carry over. So I don't want people to feel intimidated that they can't do it. The big things I think that are different are, one is being good at user research, or at least leveraging user research. You're not designing for yourself here. I'm very different from a patient in Nigeria, for instance. I'm very different from my job is very different from a healthcare worker, even in America, let alone in Nigeria or India, right? So you have to leave the idea that you're designing products for yourself at home. You're definitely not. But that's relatively similar to designing an enterprise software, for instance, right? It's really important to understand your users' needs, listen to them, work with them, so design with them. I think that's really important, so some humility. I think it's also really important to think long-term.
Okay.
These are not easy to solve problems. And I do think there's a bit of a cultural issue in design in the last decade, that we really admire people who solve relatively easy problems. Oh, you worked on this thing for 2 years and it sold for $100 million. Amazing. And that is amazing. And don't get me wrong, I did well in Silicon Valley, and some of the startups I worked with were relatively trivial. So I'm not going to make fun of people for working on things that aren't the most important thing in the world. But working in public health is a marathon. Nothing is going to get solved in a year. It's more like working on a problem for a decade. If you really are genuinely into it for the impact, you're into it for a long time, because the problems by definition are hard, right? Improving primary care in Nigeria, which we're starting to work on right now, literally in Nigeria, is a hard problem. But if you were able to do it, it's almost 300 million people in Nigeria, you could have a lot of impact. And many of those people are going to public hospitals for primary care. There's a huge amount of potential there. The other thing is, it's kind of the Wild West again. When I first got into design in 1998, 1999, a long time ago, it felt like you were inventing the wheel all the time. We were all just discovering how to do things, and public health is kind of the same way. Almost none of it's rocket science. It's not oh, we need artificial intelligence and the blockchain to solve this problem. It's building blocks of usability. It's political will. It's bringing people together to build consensus across groups. It's all this basic building block stuff, but you're bringing design to a place where it's sorely been lacking. And that's a great feeling. But you can't just walk in there and be oh yeah, we're going to do a design sprint, and then we're going to do an agile, we're going to do an agile development method to build an MVP. Everyone would stare at you like you're speaking a totally different language. You genuinely feel sometimes like you're speaking a different language than the people you work with. Our public health team, they'll say things hilarious shit what did they say the other day? They're oh yeah, we'll just talk to NORAD. And I'm looking at them, I'm the Missile Defense Group? And they're no, that's a health group you've never heard of. And I'm what? How was I supposed to know that? Or they use acronyms that we would use in tech to mean totally different things. And you're I literally don't speak the same language as you. Like the number of acronyms health people use is just out of control.
Oh, wow.
Yeah.
Wow.
I mean, tech people are bad enough. Health people, it's crazy. I had literally had a conversation the other day that the WHO was sending us NPCDCS data about HTN and DM so the HCWs can do the NPCDCS register. And I'm like, I can't believe I know what that all means.
I have no idea. I have absolutely no. The only one I get was the WHO. Everything else, I have no idea about.
3 years ago, I wouldn't have known what any of that meant.
Oh, you've been doing this for 3 years or more?
Yeah.
Oh,
only
wow.
3 years. Yeah, I'm still learning. I'm a novice here. There are people who've been putting in decades of work in public health. So, kudos to them. I'm a newcomer by many measures.
Okay. Wow. So in essence, what you're saying is that if somebody was going to try this kind of thing, they'll need to know how to do some research or leverage on what's existing. They'll be humble. They'll need to learn a lot because clearly this is a new space. A lot of data doesn't even exist for this. It's not like you go Medium and see articles about how to be a great designer in public health, right? So since we're talking about data, I've also been reading the comments and a lot of questions are coming up about data. What do you do? How do you glean your data, and how are there some methods you go about it so that you can both get the right data and then be able to preserve them and have them reach the right people who need this to work?
Yeah. So the big challenges with data usually are that people in some ways collect too much data, especially in low and middle income countries. This might be surprising. The humans are complicated and healthcare is complicated. So everyone assumes you have to collect a lot of data. And in some ways you do, right? I mean, human beings and human health is very, very complicated. But if you think, so in a very pragmatic way, in low and middle income countries where you see this kind of high volume patient care. So this is not like someone came in for cardiac surgery in a tertiary hospital. This is high volume care in primary clinics. So like kind of the normal clinic you would go to for a cough, where they take your blood pressure and take your weight and like they treat you over time. There are kind of two types of data in a primary care. There's transactional data for today. Like, what do you need to know about me today to treat me right today? And then there's data that you need to treat me over the long term.
Oh, okay.
Data that you need to treat me today, you can write on a piece of paper. Paper works great. If you look at Ethiopia, for instance, there is just enormous amounts of paper in the hospitals. You go into the records room, it's just stacks of paper all falling over, just like thousands of records for all these patients. And it works okay. If all you're doing is treating the patient today, it works pretty well. If you're trying to treat a patient over time for chronic disease, something like hypertension or diabetes, what you really want is a longitudinal record. But then you can think, well, what's the minimum amount of data I really need in order to treat that patient successfully, right? And then you have to look at what each character in that ballet needs. The patient, she needs to know, is her blood pressure decreasing over time, right? That's the primary metric for her. The healthcare worker needs to know, what was the patient's blood pressure the last time, and what's the patient's blood pressure this time, and what medications did I give them last time? Because if their blood pressure is still high today and it was high last time, I'm going to take their medicines and increase the medicines to the next step in my treatment regime, right? They're on amlodipine 5 today. I'm going to increase them to amlodipine 10. Nope, they're on amlodipine 10 today. I'm going to give them amlodipine 10 and telmisartan 40, right? So it's these kind of common treatment algorithms. At the higher level, all I need to know is which patients are coming back to care and is their blood pressure controlled this time or next time? If you boil it down to what data you'll actually use, you can really reduce the amount of effort for data entry. Because this is a chronic problem in healthcare. Even in North America or Europe, where clinicians have 15 minutes with each patient, They complain that they spend 5 minutes typing data into a computer at the end of every visit. This isn't a good use of their time. They didn't train to enter data into a computer. They trained to look at the patient across from the table and counsel that patient on how to be healthy, right? It's even more acute in somewhere like Ethiopia or Nigeria, where you have very high patient volumes, right? And so if you can reduce the amount of data being entered to exactly the data that's needed, not the data that's interesting, not the data you might investigate later, the data that is useful for monitoring a program and treating patients, you can really streamline a system that works within the pragmatic needs of that time constraint.
Wow. So I'll ask this because I know, like, I mean, I'm a Nigerian, I live in Nigeria, and I definitely know that collecting data is a huge problem. So is it like how would I put this now? So obviously, papers will probably not do a good job, because if you're going to have to look at that data over time, you still need that linked in somewhere. So have you found, like, maybe the best way for them to improve this? So is it an app? Is it a software? Because a lot of times as a product, then I have people come to me and say, hey, I'm trying to build this and I'm trying to help the health sector, and I think we could build a software. Some people say, no, I think an app would be better. And sometimes you get room to do some research and it looks like it's gonna work. Some other times you don't do any research at all, and they're like, I just turn this out really quickly. So in your own experience, what do you think works best, if I'll put it that way?
Okay. So from our experience in the last 3 years, there is a good opportunity to use apps here. So an app is not always the solution. Let's be clear. Yeah. In this case, paper fails because, one, you have just giant patient volumes, right? In a hospital, if you have 2,000 patients and you have to go find the patient paper record every time a patient comes in, it's unrealistic by the time you've got 2,000, 2,500 patients registered, right? It's just a huge burden on the system. Also, because patients move around a lot in chronic care, so they might come to the little village clinic today, they might go to the city hospital tomorrow, they might be treated in their home by a community health worker the next day, right? A paper system isn't portable, right? It lives in one place, and so you end up with a disjointed patient record because of that. And then also, patients missing care, so basically being lost to care, is a huge problem in chronic disease. And on a paper system, it's really hard to automate the kinds of things you can do, like sending text messages or automated calling to patients to try to return them to care. So a digital system works pretty well. Particularly in India or Bangladesh or Ethiopia or Nigeria, the mobile phone is this giant opportunity, right? You saw this in finance already in Africa.
Yeah.
The mobile phone was kind of this leapfrog technology. You can definitely pull this off in healthcare. So we have about 4,500 healthcare workers in India right now using the software I make, which is Simple. It's called Simple, simple.org, if any of you want to look this up. If somebody wants to put that in the chat. It's a good domain name. So that tool, healthcare workers are actually using it on their personal devices, which really reduces the capital cost to a healthcare system. Normally, they're buying like computers or tablets for all of their hospitals, which is enormously expensive at scale, right? But one of the first things I did when I was touring India, I was going to all these hospitals, and I'd ask the nurses, like, hey, what phone do you have? And they looked at me like I was freaking crazy, because they're like, what? Are you trying to buy a phone or something? And I was like, no, I'm just curious. And they'd pull out of their pocket a good smartphone. 99% of them had a good smartphone. And this is like at public hospitals in rural India. So the penetration there is excellent for smartphones. So it's a really good opportunity. Similar in Nigeria, Ethiopia, a little less common. So we do a lot of purchasing of devices in Ethiopia. But the software enables us, combined with a kind of a paper system. So we have a paper card for the patients with a QR code on it, and then an app that the healthcare workers can scan and then record the patient. that combination has worked really well to move patient data around the hospital. So the paper card kind of goes with the patient around the hospital with a little bit of data on it. The long-term data is all stored in the app. And right now, the median time to enter data in the app is 14 seconds. So we're taking up 10% of the patient visit, 14 seconds.
Wow.
Right? 14 sounds really fast until you say it's 10% of a patient visit. And then you're like, shit, that's a lot of a patient's visit.
Yeah.
But that's about as fast as we can get it. Yeah.
So an app works. Okay. I'm taking note of that.
It works for the specific problem I'm working on. So your mileage may vary.
Okay. So
do your research.
Okay. Sure thing. I will do my research. So I would also want to know, are there other design methodologies or practices that you also use with working in public health that makes the whole process a whole lot easier for you?
Yeah. So one of the biggest things we do is a lot of prototyping. So we do a lot of high fidelity prototyping. So the way that we actually develop the software, so I run both product and design here. So I'm driving our product roadmap as well. And we're using design a lot to try features with healthcare workers before we ever develop them. So what we do is we mock up, kind of like right now, for instance, we're working on the ability for healthcare workers to download an entire list of their patients to be able to distribute it to community health workers who are working in the village. And it's a lot of work to engineer that. And there's a lot of ways to do it. So the first thing that we do is we go talk to healthcare workers and we ask them, how are you doing this today on paper? And what do you need? And then we do our best to prototype a function, right? So, okay, do you have to be able to filter this line list? You have to be able to sort the list of patients so it's highest risk patients first, or patients who are like have the most recent visits first, or older men or older women first. I don't know. And so we go and prototype how to do this, and then we go back out in the field and we show it to healthcare workers and we have them try to use it. We're not asking for their feedback. We have them like using our prototype. Do you see the difference?
Okay.
I don't want them to like, oh, I love your prototype, I would change it in these ways. It's like, I want them to try to filter a patient list and be like, I'm confused by this, or no, I need it to go this other way. I need it to be different than this. And then we learn and we go back and we try another prototype. And once we're confident of our prototype, then we put it in the engineering roadmap. So that's a very, very powerful tool to be able to test real ideas with real people very quickly, and to reduce the risk that we're wasting our time on engineering, or that we'll screw it up in the field. Because you really can't, the Facebook idea of move fast and break things, you cannot do that in public health. I mean, you can't do that in health at all. The first rule is make sure you don't hurt anyone. So we're able to kind of try radical ideas and try new things in prototype form with real healthcare workers. Not like the officials at the Ministry of Health, not like our favorite doctor who, is willing to spend time with us, with real healthcare workers to be able to see kind of what their reactions are and what their feedback is to us. And that type of user research coupled with prototyping is like fundamental to our process. We're probably testing prototypes every 2 weeks.
Wow.
So we have a lot of engagement with healthcare workers. Yeah.
So since this is obviously a whole process, how long does it typically take you to come up with, say, a feature or something, test and have it eventually? What's the timeline?
So we have a fairly agile method here. A lot of health software is very slow and has to be very careful.
Yeah.
We're careful with prototyping. We prototype things before we make them. But we're pushing out improvements to the software probably every 3 to 4 weeks. So we have fairly high cadence of releases. And to get an idea from ideation to prototyping to testing to iteration to testing again to engineering to release, it's probably 5 or 6 months usually. takes quite a while to get something out into the wild. But by the time it's gotten into the wild, we've had it in real healthcare workers' hands to get their feedback already. So, you often hear this, Steve Jobs was really fond of saying that real artists ship, because he had the idea, and I think he was right, that it's easy to doodle in your room for a year. It's hard to actually launch something. But prototyping and testing is this kind of shortcut to launching. We're not actually launching real software, but we're getting it, getting real world feedback earlier in the process. And I think that's a real kind of magic trick, especially in public health, where you can't realistically launch things super fast.
Okay. I think I think a lot of the times we as designers, we talk a lot about prototyping and testing with users. And honestly, in the real world, a lot of times you also get to meet with stakeholders, team leads, line managers that really do not care. They just want you to design something really quickly so that we can push it out there, and then we'll see how it works. And it's crazy, really, because a lot of times you launch something that really doesn't work, or works somewhat, but has a lot of problems with it, and then you have to rebuild. So I'm happy we're having this conversation, and I'm happy you're seeing this, because I'd also like for newbie designers to have it in their subconscious, the very importance of prototyping and testing. It's not something that is a great idea to overlook. A lot of times people have gone ahead to just build things and ship, and then you waste money, you waste time, you waste resources shipping something that doesn't actually work. So public health, consumer products, B2B, whatever it is, guys, prototyping and testing is important. Thank you. So at this point, I think we'll just take questions from the comment session. We have another, okay, that's 18 minutes. So we'll just take questions from the comment session. So I see one from Rosmia. Hi, Rosmia. You were here yesterday, you're here today, and thanks. And thanks everyone who was here yesterday, who's here today again. You're at best. So he says, isn't that patient centricity ecosystem that you're trying to build?
That is exactly the patient ecosystem that I'm trying to build. So, and the interesting thing, Rusmir, is what I just described is actually health worker centric. So one of the challenges in health is that your users are not only the patients, or not only the healthcare workers, or not only the officials, right? It actually is all three. And so a user-centered system, a real user-centered system, actually has to satisfy all three of those. Because you could make something that's great for patients that doesn't help the kind of the system administrator, so the minister of health, or the nodal officer for hypertension in a state, see where hypertension is being well treated, and that is a problem, because you could you have to fix a bunch of systemic issues in order to fix hypertension. You could, oftentimes software is designed specifically only for that person, the minister of health. In that case, you have to make sure that the healthcare worker or the patient's voice is heard. And really it's, the patient, the patient's family, the healthcare workers, which is a whole group of people. I'm generalizing. It's nurses and doctors and pharmacists and the woman who works at the outpatient desk at the front door. It's all of those people. And your job is to kind of, back to the dancing metaphor, is to make sure that all of the dancers in the ballet get their needs met and balanced, so the system works in the end for the patient. Yeah.
So, any other questions, guys? Just drop your questions here. I'll just scroll through to find them. Okay, so I'm seeing a comment here about getting a digital record keeping, but having problems with being able to track data. So how do you handle that?
Well, there are a bunch of reasons why data is hard to track in digital systems. The first is that the if the data is not really easy to enter and not super clear to the healthcare worker about what to enter, you end up with this problem that public health people like calling garbage in, garbage out. If you ended up with garbage data coming in, you're going to end up making a bunch of decisions that you think is based on rational data that is actually based on garbage data, right? Like there's a really good example. Like if I say, if I had a question, does the patient have hypertension? Yes, no. The nurse is going to look at that and be like, well, I think they have hypertension, so I'm going to answer yes. Does that mean they have hypertension? Maybe, maybe not. If I say, is the patient diagnosed with hypertension? They're much more likely to say, yes, they're officially diagnosed. No, they're not diagnosed, right? Or, we just ran into this problem the other day. We were trying to figure out if patients were previously on care or if they're a new patient in the system. Well, what question do you ask for that? You have to, should you ask at all, right? Is this really important data or is it going to impact our 14 seconds, right? And if it is important data, how do we ask that question? And Dr. Prabdeep Kaur, who's works with us from the Indian Council of Medical Research, she's done hypertension work for the last 15 years. And she was like, listen, the only way to ask that question is to say, has the patient been taking hypertension medicines in the last 30 days? And there was a big debate with the WHO, person we work with and some field workers, and they were all debating kind of more abstract language. And she was like, put her foot down. She was like, if you ask this in any less direct way, you'll end up with garbage in, garbage out. Because it's a very specific question you can ask and have a very rational answer to. Okay, so that's one problem. The second is that patient data systems often don't flow together. So the pharmacy might use one system, the hypertension program, so my system might use a different piece of software, and the HIV program or the antenatal care program for mothers might record in a totally different system, like literally different software. And if those software don't talk to each other, you could be entering blood pressures for all the mothers in the antenatal care unit. None of that will flow into the hypertension control program. This is a perennial problem in healthcare. And it's if you hear people talk about interoperability, this is what they're talking about. Huge problem, especially for things like epidemic preparedness, where you need data to flow together quickly to be able to make rational decisions fast. Like, how am I supposed to know there's an outbreak happening if fever is being recorded in 6 different systems and isn't all coming to the center to be reported that, like, wow, everybody's got fever in this in this region in the last week. And then the third thing with data is the problem of dashboarding. And this is a really interesting design problem, is decision makers need good dashboards in order to make decisions, but what indicators are you going to put in your dashboards? So literally, what's the math? You wouldn't believe how often I talk about numerators and denominators in my job now. Like, welcome to design, kids. By the time you've done this for 25 years, you're just going to be talking about math and project management. But it's really interesting because you're thinking about, like, fundamentally, we're designing a system to report this data. Well, what are we reporting? And so you have to talk very specifically about who's in the numerator and who's in the denominator to report things like blood pressure control. It's patients who are diagnosed with hypertension, who aren't dead, and who have visited at least once in the last 365 days. That's my numerator. My denominator is patients with a controlled blood pressure at their last visit in the last 90 days. Stuff like that. And the key, before you design a beautiful dashboard with beautiful graphs, is to make sure you're actually showing the right data. So you end up convening a group of health people and a group of technology people, and you all come together for a little workshop, and you figure out, okay, what's the data we're going to report, and what's the most important data to put at the top? Because you know that Deputy Minister of Health is going to look at that for 10 minutes and make a big decision. So you better have the most important data first. That is design. I know that may not sound like design because it's not using Photoshop and choosing good colors. But you, first of all, choose the fundamentals, then you do great design, and then you change the world.
Wow, I like the order. So we have another question here from Sanusi Victor. He says, how do you push a user centricity product in a bureaucratic system?
Yeah, that's a great question. First of all, let's acknowledge it. It's really hard. So you're going to feel like you're banging your head against the wall, and sometimes people won't listen to you. And I'm in a very fortunate position, right? I have a good technology team. I have a large budget, and I work with the former director of the CDC, so I get listened to when I'm in rooms. If you're more junior in this system, it's going to be even more difficult for you. I think the important thing to keep in mind is those bureaucrats, for the most part, do care about patients. They really do. They might say some crazy shit, right? Like I was in a room with a bunch of bureaucrats in Bangladesh, and this very important older cardiologist got up and he said, we must make sure that every patient has 2 blood pressures taken and a serum creatinine lab. And they wait 15 minutes between the 2 blood pressures. And he said this with a straight face. And I'm looking at him and I'm like, when was the last time you were in a hospital? Like, there's literally 400 people waiting in the waiting room, and they're all being rushed through in this very busy line to be treated. There's no way you could actually do that realistically. He's not stupid, and he does care about patients. So you have to keep that in mind. But he hasn't been in a hospital, or at least hasn't been in the room where patients are being treated in a decade. And so I think it helps a lot to do that user research and bring pictures and bring stories from the field and be like, hey, I love what you're saying, but I was just in one of your hospitals that's in your district, and let's look at what actually happens in patient care right now. And then you can really talk it through. It also, I swear to God, branding works pretty well. This is going to sound really dumb, but calling this project simple is probably the best branding work I've ever done in my life. Because it's called simple, you end up in these meetings with these bureaucrats, and I swear to God, you walk into a meeting and these people are like, okay, so obviously my state is much more complicated than any other state. Everyone thinks their patients are different than the other patients. And they're like, we're definitely going to need to have these 3 other features. We need to measure BMI. We need to measure, this, risk analysis for every patient. And you're like, okay. Like, what does that entail? And then they start spelling it out and they start describing it to you. And then they're like, well, hang on a sec. That's not simple anymore. And you're like, yeah. They literally use the word simple over and over again in the meeting, and I don't even have to open my mouth. I'm just sitting there with listening intently, and they're like, oh, it's not simple anymore. Okay, we shouldn't do that. We shouldn't do the other thing. In fact, we shouldn't do any of it. we'll just do the basic thing. And you're like, yes. So you don't win every battle, and we do add things sometimes. But it helps user research, a little bit of explanation about why simplicity matters, and then remember what you're measuring. Right? We always talk about time measurement because we're like, your healthcare workers have 2, 3, maybe 3 minutes with every patient. How long do you think it will take them to fill this out? And they're like, shit, it's going to take 30 seconds, 45 seconds. And you're like, that's a quarter of the patient visit. A quarter. That's unbelievable. They don't have time to do anything else. And they're like, okay, we shouldn't do that. And you're like, yeah. So I think, bringing people along, but you won't win everything. You definitely aren't going to win every battle.
Okay. All right. So let me check and see if we have any more questions, because we have 6 minutes to go and we do not have. So guys, put your questions. So it's not when he goes, then he will come and be asking me questions. I can answer.
Thanks, Janela.
Yeah. Okay, you're seeing that. Yeah. All right. So in the absence of any more questions, I think we're just gonna call it a day. It's been a great session. It's been super enlightening, honestly. Honestly, if there's anything I take away from this session, is that design can change the world, literally. So Daniel, thank you so much for your time. I really appreciate this, and I think in the future, I'd like for us to have more conversations around this because uh, it's very we as designers have been put in a box of tech products, and if it's not an app, if it's not this, if it's not that, it's, you're not useful anywhere else. So I think more conversations need to be had around other fields where design is needed, and this is honestly why I got into design in the first place. I think at the time I remember seeing Jacob Nielsen, was it? Some of these guys actually talk about not just apps. I think he talked about the first mouse that Apple had, and I saw physical products. I saw services, systems
Yeah.
that these guys just sat down, really thought about, did a lot of research, and then they came up with a very awesome solution. I'm like, I want to do that. Well, thanks really, because this has gotten me.
It's it's
Go
still the
ahead.
Wild West. I
Okay.
remember back in like the early 2000s, it was great. Like we were inventing the internet. Like I helped invent the thumbs up button to vote up on things. Like it sounds dorky now, but like we did this on Dig, and then Facebook did it a year or two later, and like it felt like we were inventing the internet. Like I sat down with Mark Zuckerberg once, and he was like, "I think we should have profiles." And you're like, "Oh, I mean, he's cool." And like, can you imagine having a social network without a profile? That wasn't a thing at first. Like people invented this stuff, and then we made them on the product I was working on. I think every generation, every group thinks that like, oh, the world's already been invented. And there's so much room to still make new things. But it's not retreading the stuff other people have already done, right? Like there's big worlds out there that haven't really been scratched by design. And the nice thing is, you may not make millions of dollars working in public health, but it's the Wild West. Like there's just huge areas for impact. There's lots of low hanging fruit opportunities, and yeah, you're definitely needed. But you're gonna have to teach a lot of people what design is and what user research is. And don't use the word research; they freak out because they think it's like medical research. And you're like, no, we're just gonna talk to people and listen to them. But there's just so much stuff to do. So I encourage you all to like find your niche. And remember that design's a huge umbrella. There's brand design and product design, like the mouse you're talking about. There's, designing in code. There's designing data visualization. There's system design. There's paper, designing paper systems. Like we're doing all of these things. Like all of that is part of the simple.org project. And like you can focus on one thing. You can do a bit of all of that, like I do. But don't let anybody tell you that design is just one thing, or it's just like if you're not designing the way they're designing, you're doing it wrong. Like fuck those people. There's a million ways to be a great designer, and just find your own path. There's so much opportunity. Sorry, I was ranting, Angel. You gotta stop me.
It's okay. It's okay. Yeah, it's like that was a lot of very powerful message, honestly, for me, and I'm sure a lot of them feel the same way. Yes, they're mind blown. I can see that. So thank you so much.
Thanks, Abraham.
Yeah. So thank you so much for coming on, and I hope we could have a more extensive conversation about this. And if you ever come to Nigeria, just holla.
I should be in Nigeria by the end of the year.
Whoa. Okay.
So I'm working with a team in Abuja right now. Where are you?
I'm in Enugu.
All right. I will hit you up. I've been working with a user researcher named Praise, who's based in Lagos. I don't know if you know her. It's a big country. But yeah, I'm going to be in Nigeria as soon as I can with COVID. Yeah.
Okay. Sure. So just definitely hit me up, and then yeah, we can have a whole conversation face to face, and I'm sure these guys will love to see that. So definitely do let me know when you.
Oh, there's a bunch of Nigerians in the chat.
Yes, a lot of Nigerians in the chat, a lot, and they are.
Hey, Precious is in Abuja.
Yes.
Maybe I'll see you there, Precious.
Yeah, so they're excited to have you here. Yeah, so thank you so much, Daniel. It was a very awesome session, and it's really inspired me to go back to some of the things that made me get interested in design in the first place. Honestly, these days I've gotten lazy, and I've gotten used to just apps and Oh, Daniel.
I froze for a second. I'm back.
Yes. Okay. Okay. So it's I've gotten lazy, but thanks really. I think I need to get back to what made me interested in design and look for new opportunities, new niches like you mentioned, and I'm sure everybody here would like to explore. So much.
Awesome. Take care, everyone.